Welcome to the Voices of Healthcare Equity podcast. I'm your host, Kim Tranquata. I am the founder and CEO of Healthcare Alliance for an Equitable World and a board certified emergency physician. After 25 years in healthcare, Healthcare Alliance for an Equitable World is the expression of an overwhelming desire to do more today to address healthcare inequity across the globe. There's currently a global shortage of 6 million physicians and several million other healthcare workers, including nurses, midwives, dentists, and pharmacists. With Healthcare Alliance for an Equitable World, we are using telehealth to bridge this global healthcare workforce gap today. And we are building a global community of healthcare workers who can do the work of global health on a regular basis from their home. This podcast, Voices of Healthcare Equity, is one way we are building this community. This podcast will feature conversations and insights from innovators in global health. We will gain insight and perspective on the current and future state of healthcare across the globe. I am inviting you to join us in this community and in our mission to make a lasting and scalable impact on global equity in our lifetime. Today's episode features Chandramouli Samatham, founder and CEO of CARE. I met Chandra 1 year ago, and as we met on a Zoom conversation, we discussed our shared interest in telemedicine to bring telehealth to work and telehealth expertise to rural and under-resourced communities. While we have been on similar paths on different sides of the globe, Chandra has always treated Healthcare Alliance as a collaborator and not a competitor. I am very happy to have the opportunity to reconnect with Chandra and share with our audience your progress and developments with CARE in India. Welcome, and thank you for joining us.
Thank you, Kim. It's a pleasure to be here, and thank you for this great opportunity to connect to the audience and talk about our journey.
Before we go into our conversation, do you have any affiliate disclaimers or any conflicts of interest you'd like to mention?
Nothing specific, no.
Excellent. Well, let's start with the how and the why. How and why did you become involved in global health?
So this happened, I think, I would say around post or around COVID. I mean, obviously, COVID has been the biggest driver of this change, right? And around that time, I was in Ireland. Actually, I finished my MBA and I was trying to settle down in Ireland around that time. And basically, I did not have any medical background, or I do not come from the healthcare background, right? But obviously, COVID kind of changed the entire, I would say, sector. I mean, every sector, right? For that matter, there were obviously no jobs, and everybody is struggling. And for me, also, it's the same situation. It's nothing different. And also, COVID also made me realize that I think my presence in India is more required than anywhere else. So I decided to return. And once I returned to India, then I had the opportunities because of my experience in the edtech. I was basically working in the edtech industry, educational technology. And so I had a lot of opportunities to kind of join back that community, but I wanted to do something different. And healthcare was very close to my heart, primarily because my father-in-law is also a doctor and who's been serving in a rural community uh, uh, very close to my place where I live currently. It's around 5 hours of journey. So there he has been serving for almost like 45 years. And obviously, because of the retirement and unavailability of quality healthcare in that small town, he returned to the city where we currently live. And by the way, I live in a place called Vishakhapatnam in Andhra Pradesh, one of the southern states of India. So, as I said, once I came back to this place, I saw him. Obviously, during one of the thing is around that time, I saw many people started utilizing telemedicine, or I think I would say broader perspective telehealth. And and I saw a lot of advantages as I being a technical guy. So I saw the flexibility of it and the affordability of that. I realized that a lot of people are really benefiting out of that solution. And the on the other hand, what I also saw was in the rural areas, there was hardly anything. I mean, there's nothing moving. Uh, Nobody was able to utilize it because most of them did not have smart devices like you and me. Like we all have a smart device where I could probably connect to a doctor, probably download a um, I would say billions of apps are available on the internet, on the app store, telemedicine apps. So you download one of them and connect to a doctor. But unfortunately, yes, smart devices are not there with the rural communities. And even if they had, I don't think they had the ability or the capability of connecting to a doctor on their own, right? Because of the literacy issues. I mean, many of them are not well educated, or I would say not aware, or they don't have knowledge about this. So I would say telemedicine, even though around COVID it did wonders for urban, I think rural, it kind of fell flat. Nothing really happened there. And I think that's when I realized I think telemedicine will not work. The urban model of telemedicine will not work for the community, rural community, right? And around the same time, I think one of the instances where I saw my father-in-law kind of helping a patient out in the village with the help of a nurse, with the help of his own nurse who was working with him in the past. And that made me realize that I think there is an opportunity here if we are able to, I would not say twist it, but if you're able to offer it in a different way, which doesn't burden them on the need of the technology device, on the need of the knowledge, on the awareness, I think people will have probably may benefit with this solution, right? And then that's when I started exploring this idea, and then I started building the app itself. When we tried and tested, ran several pilots. So, so end of the day, I mean, what we have basically done is we have created an app. We call it a Care Doctor app, which has the ability for a doctor to log in and a health worker also to log in from both the sides. And the health worker will basically facilitate the patient through the entire process, wherein the patient doesn't need to carry a device, neither he has to understand the concept of telemedicine. So the health worker will be able to connect them to the right doctor and then help them through the entire consultation process itself. And one of the other major advantage I feel in this model is unlike the urban model of telemedicine, where there is always uh, difficulty of sharing vitals, right? I mean, you don't have, I mean, you as a patient will not carry all the vital devices, I mean, to check vitals, that the possibility is very less. And as you know, most of the time, doctors do not believe patients. I mean, that's the one of the concept, like where you doctors do not believe patients. I mean, they would rather believe a health worker or a nurse who are who's assisting them. So I think in this model, this assistant model, I think even that gap is also that whatever the gap which is there in the urban areas where there is no way of exchanging or sharing vitals, even that is also eliminated because the health worker is able to take all the necessary vitals, prepare the doctor with all the necessary information, which again doctor can use it as as valid data for them to provide the consultation. So I think that's what we are doing. We feel I think telemedicine is the future, or telehealth, or whatever we call it. So it is again definitely the future, but I think it has to be served slightly in a way which can be I think useful for the communities, uh, as I mentioned.
So I heard a little bit that what you are doing is customizing it for the community that you're working in. But what's really interesting about the way that you do it is that you work with the local healthcare worker instead of direct to the patient, especially in rural areas, underserved areas. You're not competing or undermining the local healthcare system, but you are helping, engaging with, and uplifting the local healthcare system. What are your thoughts about that?
Yeah, I think really, if you see this in this model, what we are trying, I think there is an ability to also create opportunities for the health workers. Like one of the clinic which we are setting up here in Kerala. So obviously, city has tertiary care where they have multi-speciality doctors, and you have cardiologists, nephrologists, neurologists, and all. I mean, you can't imagine having such specialists accessible from a rural and a remote village, right? I mean, all you get in a remote village is a general physician, and sometimes even general physicians are not available, right? Because I mean, in India, unfortunately, there's something called there are people who are unqualified doctors. We call them quacks, right? They're spread across everywhere. So a lot of people, rural people, I mean, forget about the general practitioner. I mean, even you don't get a proper doctor there. Now, if you can imagine, what we are trying with our model is that we are now are able to enable or give them access to these specialists like cardiologists, diabetologists, nephrologists, neurologists with this model, where not only in their community we are enabling, or I would say creating opportunities from for the local health workers. Ideally, local health workers whom we are actually onboarding on our platform at the rural side is typically somebody who's done probably a nursing degree, or we call them A&M or GNM, uh, so which or a paramedic who's got some basic qualifications, who are able to kind of please diagnose the patient, take their vitals, and share information with the doctor, right? So we are creating opportunities for them, and from we are trying to find people from the same community so that they can manage their own community members with ease. Because again, end of the day, it's all about caring. So the idea actually, right, kind of works very well. So yeah, that's what we are trying to do. So yeah, one point is right that we are trying to create opportunities for the local health workers as well.
Yeah. And context is probably important. We have an American audience here. I hope we have a global audience as well. What can you tell everyone about A, what does the healthcare system in India look like? So that they had just some context about what you're working in, and how are you able to use your model within that healthcare system, because your model would have to change based on the healthcare system you're working in. Yes.
Yeah. So in India, the healthcare hierarchy goes like this. Like the first point of contact, I would say, in the healthcare system, it's called subcenter in India. Basically, that subcenter serves up to say 5,000. I would say beneficiaries, or the community members, or the population, you can call it. And uh, and uh, then again, um, when you put five subcenters together, then under they form a PHC, primary health center. So primary health center will serve up to say 60,000, I would say, uh, 30 to 60,000 people, or the population size, right? And then above again you put five PHCs together, then it becomes a community health center. And then a different community say health centers put together becomes a district level, or it district level hospital. Then you have these tertiary care, like a I'd say urban care, right? So the hierarchy goes like this. The top, obviously, the most uh, uh, I would say the bottom level of the initial care is the subcenter, we call it. Then we have PHC, then CHCs, community health center. Then above that, district level hospital, then after that, the tertiary care, or I would say urban care. Now, at the sub-center level, typically what we have is it's a government run, I would say central and state government run facility, which has A&M. Typically, a qualified nurse is there with, I would say, community health worker as well. So that's it, and they don't have anybody else. They don't have doctors and or any practitioners there. Um, but in a PHC, they are there. There are some doctors. Ideally, they have at least one GP and expected to have at least two specialists. But most cases, they will again have probably just one GP. And from there, if you go to the community health center, there ideally you are expected to at least have 8 to 12 specialists, along with probably 10 bedded hospital kind of a thing, which is a community health center. Now, you can imagine, because India is quite vast, and the sub-center distance for a rural community, like obviously it'll be in one place, and there are several villages around that. Typical distance is around 5 kilometers for them, which is not able to convert in miles, but yeah, approximately 5 kilometers. And a PHC would anywhere probably come between 15 to 20 kilometers. And then a community health center distance would sometimes be beyond 30 and maybe 60 kilometers, right? And so that's how it is. So now the first, more or less, you'll really find a proper doctor. I would say he's almost like 30 to 40 kilometers away from your place. Imagine that is the scenario there, right? And and unfortunately, again, in the rural setup, again, the roads are not so great, the terrains, right, and all that. So there's so many challenges for them. So yeah, looking at that perspective, so what we are also trying to see is how we can upgrade those sub centers, right, with our model, wherein suppose as it is, every sub center has a nurse, right, or a community health worker. So what we are trying is we are trying to explore some pilots as we speak, is to give our platform and then enable them to connect to doctors from that center itself, right? I mean, so end of the day, we want to unfortunately, what the problem is, when they go to the villages, when they go to the sub center, um, they are probably sometimes given some medicines and asked to, if they are if they don't become well, they are asked to go to PHC. They go to PHC, they'll not find a doctor, then they are asked to go to the CHC, and have been like traveling, and unfortunately, most of the time they don't get proper treatment. And so the challenge is, even though the facilities are there, there are no doctors, I would say, available. And most of these government doctors, obviously, they are busy, and as it is, government is doing a lot, obviously, but still, I think there's a lot of gap compared to the world index, as you know. For every each state is different in India. Ideally, I think or a 1:1,000. So for us, it goes beyond that. Sometimes it goes probably 2,000, 3,000 range. So yeah, end of the day, I think the physicians are not there. There are a lot of physicians in the city, right? I mean, if you come to a city, Indian city, even any tier one cities, so you'll find a doctor in every street. I mean, there are so many doctors for urban population, and most of the doctors who are once graduated and qualified, they would always like to settle down in cities. I mean, they don't want to go to rural areas, right? So the challenge is doctors are not willing to go to rural villages, and we cannot change that behavior, right? I mean, you can't push them. There could be a very small percentage of people who wish to go back and probably serve in the community, but a lot of people have invested a lot. I mean, end of the day, it's all about the cost of the education, right? MBBS is very costly in India, or probably every across the globe. So ultimately they would settle down for whatever reasons, for family and other priorities. So as we can clearly see, doctors are not willing to go to rural villages. People from the rural villages are finding it very difficult to come to the cities because of the kind of infrastructure or the model we currently operate in India. So the best way is to find a way wherein it can be served, right? So our model fits into that equation perfectly. And as I said, what we are trying is trying to find a way wherein we can upgrade these subcenters, where we kind of upgrade them, basically enable them through our platform, so that those nurses or the community health workers from there can connect directly to the doctors from the same, and patient doesn't have to travel to all these centers, right? So the idea has already been proposed. We are exploring some opportunities here, so hopefully uh, we'll see some good results in the coming days.
Wonderful work. We're going to take a brief water break and we're going to return to our conversation in 1 minute.